So Amit sir told that he's joining little late. So let us start now. So a very good evening to all. A very warm welcome to all the fellows, delegates, faculty members, and colleagues for joining us today for Aora National Masterclass. On behalf of Aora, it is my privilege to welcome you all to another engaging academic session dedicated to advancing the science and practice of ultrasound guided regional anesthesia. Today's masterclass is dedicated to be highly interactive, clinically relevant, and evidence-based. Rather than focusing only on the technical aspects of blocks, we will be discussing how to integrate regional anesthesia into the real-life clinical decision-making, selecting the right block for the right patient, balancing analgesia with early mobilization, and critically appraising emerging evidence. So today we have planned three exciting talks. There are two case discussion. One is the regional anesthesia strategies for THR by Dr. Sanika Kadam and Dr. Gayatri from Sancheti Hospital, Pune. The second is RA strategies for TKR by Dr. Zeba from Apollo Hospital, Bangalore. And the third will be a journal club presentation on iliopsoas plain block for hip arthroplasty by Dr. Sridevi, again from Bhagwan Mahavir Hospital, Bangalore. And to moderate this session, we have three excellent moderators who will be guiding us throughout the session. So the first moderator for today is Dr. Amit Dixit sir. He will be joining with us soon. Sir is a senior consultant anesthetist at Ruby Hall Clinic, Pune. He's a fellowship course leader for regional anesthesia fellowship under MUHS and holds a postdoctoral fellowship of Aora. He's a member of Board of Studies of Aora Fellowship of India and a postgraduate teacher for DNB. Also, sir is an echocardiography course instructor, both basic and advanced, under TICU Foundation. Sir has been the faculty lead for POCUS and RA workshops all over across India and has multiple indexed published articles and also Aora POCUS Spotlight series. And Sir has also contributed multiple chapters in regional anesthesia and POCUS textbooks. Our second moderator for today is Professor Dr. Ritesh Roy sir. He's a clinical director and head of department at Care Hospitals, Bhubaneswar, India. Sir is innovator of PNS guided adductor canal block, SAP and TEX block, ultrasound guided 4-in-1 block, ultrasound guided modified 4-in-1 block, the rack approach of ESP block. Sir has been Indian representative for ESRA International Committee for 3 years from 2025 to 2028. He is the EC member of Aora India, course coordinator and chief mentor, Aora Postdoctoral Regional Anesthesia Fellowship. Sir is the current president of ISSP Bhubaneswar City Branch and has received the Lifetime Achievement Award by ISA Bhubaneswar Branch in 2019. Sir has multiple publications, book chapters, and his citations are 169 and H index of 7. Sir has also received ISA National Proficiency Award in 2019. Our third moderator is Dr. Vipin Kumar Goel, sir. He is a consultant anesthesiologist at Ganga Medical Center and Hospital, Coimbatore. He is a member of ISA and AORA India. He is mentor for Aora and Regional Anesthesia Fellowship. He is faculty for many international and national conferences and workshops. He has multiple paper publications and his areas of interest are perioperative regional anesthesia and pain management and spine surgeries. So to begin with the session, since Dr. Gayatri is facing problem, we'll start with the first talk by Dr. Zeba. I'll stop my screen sharing and I would request Dr. Zeba to continue the talk.
Yes, sir. Thank you.
Dr. Zeba?
Good evening to one and all. Can I share my screen, sir?
Yes, please.
Just a minute, sir.
No problem.
Yes, sir. Sir, is it
Yeah,
visible, sir?
you can just make it to the full screen mode now.
Yes, sir. Huh.
Yeah, perfect. You can start.
Yes, sir. Good evening to all the faculties present here. I am Dr. Zeba, Aora Fellow at Apollo Hospitals, Bangalore. I am doing my fellowship under Dr. Muddi, sir. Today, my topic for presentation is Regional Anesthesia Strategies for TKR Surgeries. And my moderator are Dr. Ritesh Roy, sir, Dr. Amit, sir, Dr. Deepak, sir. So here I'll be presenting two case scenarios. So let me start with the first case. This is a 72-year-old male with bilateral osteoarthritis of the posted for left TKR. So patient is known diabetic on oral hypoglycemic agents with moderate effort tolerance with vitals are stable. Systemic examination is within the normal limits. Airway examination is MPC class 2 with adequate mouth opening and neck movements are adequate and investigations are within the normal limits. ECG shows normal and echo is good with concentric LVH and EF 60. So my plan of anesthesia for this patient will be subarachnoid block with distal femoral triangle block with IPAC block. Then the second case, here a 68-year-old female with bilateral osteoarthritis of knee posted for right TKR. Patient is known diabetic, hypertensive with coronary artery disease. Post PTCA status to LAD is done and she is on tablet clopidogrel which is just stopped 3 days ago. Her effort tolerance is moderate, vitals are stable, systemic examination and airway examination are within normal limits, and investigations are within normal limits with tropi being negative. Her ECG is normal and echo showing mild LVH with regional wall motion abnormality with mild MRTR and EF 40%. And invasive BP monitoring was also added. And my plan of anesthesia is general anesthesia with distal femoral triangle block with IPAC block. So both these patients had smooth intraoperative course and excellent post-op recovery. But to understand why these block combinations worked, we have to look closely at the target, which is our knee joint. So let's go ahead with the innervation of the knee joint. So there are mainly three nerves which contribute to the knee joint, that is femoral nerve, obturator nerve and sciatic nerve. Knee joint is divided into anterior compartment and posterior compartment. So this is the image of the knee joint, where the knee joint is divided into four quadrants, superomedial, inferomedial, superolateral and the inferolateral. This is the anterior aspect of the knee, where you can see the femoral nerve, as soon as caudal to the inguinal ligament, it will divide into two divisions, anterior and the posterior division. From the anterior division, one motor branch is given to the sartorius muscle, which supplies nerve to the sartorius. And the second is the anterior femoral cutaneous nerve. This anterior femoral cutaneous nerve is like an umbrella term which includes both intermediate femoral cutaneous nerves and medial femoral cutaneous nerve. Whereas the posterior division, it gives branches to four muscles, that is rectus femoris, vastus lateralis, vastus intermedius and vastus medialis. So these nerves, their articular branches supply the knee joint, giving the sensory innervation to the knee joint. Among all the four muscles, except the nerve to rectus femoris, other three gives the sensory innervation to the knee joint. Then comes the major sensory nerve, which is the branch of the posterior division of the femoral nerve, is saphenous nerve. It provides the sensation to the medial aspect of the knee, leg, ankle, and the foot. So here you can see the superolateral quadrant. It is supplied by nerve to vastus intermedius, vastus lateralis, and also the common peroneal nerve, where the articular branches supply, and the superolateral genicular nerve. And superomedial compartment, here it is supplied by medial branch of nerve to vastus intermedius, nerve to vastus medialis, and superomedial genicular nerve. I'll tell you about this genicular nerves in the upcoming slide, how from like where they arise, what is their role in the knee surgeries. Then comes the inferolateral compartment, which is supplied by the inferolateral genicular nerve and the recurrent peroneal nerve. And the inferomedial compartment is supplied by majorly by the saphenous nerve, which is the infrapatellar branch of the saphenous nerve, and the inferomedial genicular nerve. Sir, one small doubt. Is the full slide visible, sir?
Yes, yes, it's
Yeah, it is
visible.
visible. Yeah.
Yes, sir. Thank you, sir. Then the posterior aspect of the knee. Here it is also again divided into the four quadrants, like superior, inferior, medial, and the lateral. And it is posterior innervation of the knee is largely by the popliteal plexus, and it is variably supplied by the articular branches from the tibial nerve, common peroneal nerve, and the posterior division of the obturator nerve. As you can see in the medial mode part of the knee, where the superior is supplied by the posterior branch of obturator nerve along with popliteal plexus, whereas the medial most part of inferior is supplied by the tibial nerve and popliteal plexus, whereas the lateral most part is supplied by the common peroneal and the tibial nerve. So this is the diagrammatic representation of the capsular innervation of the knee joint, which I have explained to you. Then come the steps in the TKR strategies. This is very important because we have to know what are the steps, like what all they are doing in the surgery while performing like TKR. What are the incisions they are taking, what are the cuts they are taking, so you can understand what are the pain generators which are involved in the TKR surgery. So the person first takes the midline incision, which is around 15 to 20 centimeters. Then he is going to take the medial parapatellar approach. Here you are going to involve the skin, subcutaneous tissue. These are all the pain generators which will cause the pain once this incision are taken. Then comes the infrapatellar fat pad removal. Once this infrapatellar fat pad is removed, then the anterior horns of the both menisci are excised. Intercondylar notch is cleared by excising the cruciate ligaments, both ACL, PCL, in the posterior stabilized knee. Then they're finally going to take the bone cuts and they're going to perform a trial implantation followed by the final implantation. So in these steps of TKR surgery, everything is removed except the pain generator, that is the posterior capsule. So, what are we trying to achieve by giving regional anesthesia or performing the regional anesthesia in TKR surgery? So, our ultimate goal is expressed here in this spectrum, where you can see a patient is like walking with a walker. Then he is moving to the independent ambulation as early and as rapidly and safely possible. So, in his early phase, we are focusing to enhance his recovery by decreasing the pain, by facilitating the early mobilization, and by decreasing the complications where the regional anesthesia plays a major role. And also in his late phase, we are improving his long-term functional outcomes by decreasing the chronic pain, and thereby overall we are improving the patient satisfaction. So to Mainly for any surgery, there are two components. One is anesthesia and one is analgesia component. So in anesthesia, there comes general anesthesia and the subarachnoid block. Whereas in analgesia, there comes the regional anesthesia techniques, which includes continuous epidural analgesia, nerve blocks, followed by multimodal analgesia and the local infiltration analgesia. So let's go ahead with the neuroaxial blocks. In this image, you can see the epidural catheter is being inserted using a 18 gauge twist needle at L3 L4 space. So catheter is being threaded 3 to 5 centimeter proximal to the needle tip. Then we are going to give 8 to 10 ml of 0.2 ropin as a bolus dose. And then in post-op period, we are going to connect the epidural to 0.2 ropin at the rate of 5 ml per hour. Historically, we have all relied on continuous epidurals. But what did these continuous epidurals bring to us are the major side effects? That is hypotension, urinary retention, delayed mobility, pruritus, and also the blocking of the other limb. So, to prevent all of these things, we have moved ahead to the nerve block techniques. So, here comes the femoral nerve block. So, the femoral nerve block is nothing but blocking the femoral nerve in the iliopectineal fossa and the femoral triangle. So, I'll talk to you about the femoral triangle in the upcoming slides. So, what all branches, like what all the nerves blocked in the femoral nerve block is motor branches, which is like posterior division of complete femoral nerve, which supplies medialis, intermedius, lateralis, rectus, femoris, and anterior division branch that is now to sartorius muscle, and sensory branch majorly the saphenous nerve, cutaneous branches which include medial and intermediate femoral cutaneous nerve. And PNS guided approach can be performed for the femoral nerve block, where you can see the quadriceps twitch or patellar dance. Here, this is the femoral triangle where the femoral nerve is present, where the base is formed by the inguinal ligament and the lateral border is formed by the medial border of the sartorius muscle, and the medial border is formed by the medial border of the adductor longus muscle. Detailedly will explain to you the femoral nerve block, like femoral triangle, in the upcoming slides. So, femoral nerve block was considered as the gold standard for years because it provided very incredible analgesia. But the problem was the post-op quadricep weakness. So before I go ahead with the side effect, I'm going to show you the femoral nerve, how it is blocked. Here you can see the femoral nerve present just anteromedial to the surface of the iliacus muscle beneath the fascia lata and the fascia iliaca. Here we can see the separate sheath where the femoral vessels along with lymphatics are enclosed, which is known as femoral sheath, and lateral to the femoral sheath is the femoral nerve. So we have to insert the femoral needle by piercing the both fascia lata and the fascia iliaca just lateral to the femoral nerve. In this image here you can see that the needle is being inserted from the lateral to the medial direction just next to the femoral artery, and the drug is being injected. So the volume of around 15 to 20 ml of local anesthetic is being injected in the femoral nerve block. So as I told you, the femoral nerve block comes with a very steep price, that is quadriceps weakness. So patients land up with the quadriceps weakness in the femoral nerve block. So after femoral nerve block, there is a ratio of around 1 is to 5,000 to 1 is to 30,000 nerve blocks. You can see this. Post TKR in hospital falls are around 0.85 to 2% per thousand inpatients. In diabetic patients, they have prolonged action and motor sensory and the motor blockade. So even a single fall post TKR, it can ruin your surgical outcome. So this created a dilemma, like how do we block the sensory pain without even paralyzing the quadriceps muscle? So the answer comes here, which is nothing but motor sparing blocks. So these are the various motor sparing blocks: femoral triangle, adductor canal, dual subsartorial, IPAC, and modified 4-in-1 block. So femoral triangle block, it is a subfacial plane which is present in the upper third of the thigh just below the inguinal ligament. So this femoral triangle, it is divided into two parts: proximal femoral triangle and the distal femoral triangle. Its base is formed by the inguinal ligament, and its lateral border is formed by the medial border of the sartorius muscle, and the medial border is formed by the medial border of the adductor longus muscle. So the intersection of these two medial borders of sartorius and the adductor longus is known as the apex of the femoral triangle. If the medial border of the sartorius is intersecting with the lateral border of the adductor longus muscle, then it is known as proximal femoral triangle. So just distal to the apex of the femoral triangle, it continues as adductor canal. So the contents present in the proximal femoral triangle are intermediate femoral cutaneous nerve, nerve to vastus intermedialis, nerve to vastus lateralis, and nerve to rectus femoris. Whereas in distal femoral triangle, the contents are nerve to vastus medialis, medial cutaneous femoral nerve, saphenous nerve. And the true adductor canal content is just saphenous nerve. So this is the diagrammatic representation where I was telling the apex of the femoral triangle being formed by the joining of the confluence of the two medial borders of the sartorius and the adductor longus muscle. And here you can see that the sartorius muscle has been reflected to demonstrate the passage of the nerve to vastus medialis and the saphenous nerve along the adductor canal, which will continue to the popliteal fossa behind. So this is very nice image which shows all the triangles with its demarcation, everything. Like same things I'm just gonna show you here. This is the inguinal ligament where the two borders are joining like to form the apex of femoral triangle, and this is the apex of the iliopectineal fossa, which is nothing but the medial border of the sartorius muscle and the lateral border of the adductor longus muscle, and this apex of the femoral triangle is continuing as the adductor canal, and it till the adductor hiatus, which is a opening in the adductor magnus muscle. So next, coming to the adductor canal, it is a subsartorial canal, or it is also known as Hunter's canal. It is a musculo-aponeurotic tunnel which is around 8 to 10 centimeters, and it extends from the apex of femoral triangle to the adductor hiatus. It is triangular in cross section, and its roof is formed by vasoadductor membrane and the sartorius, and anterolaterally by the vastus medialis muscle, and posteromedially by the adductor longus muscle and adductor magnus muscle. And the presence of these vasoadductor membrane is this peculiarity of the adductor canal region. This vasoadductor membrane is porous in nature, and it due to this, the lower border of the sartorius muscle, it appears bilayered under the ultrasound. So what are the contents of the adductor canal? As you can see here in the image, the contents are like femoral vessels, including artery and vein, femoral nerve branch, that is saphenous nerve, and in 20 to 30% of the patients, literature tells that nerve to vastus medialis is also the present in adductor canal. Proximally, you will see the anterior division of the obturator nerve, which will contribute to the subsartorial plexus, is present in 70 to 80% of the patient, and distally, posterior division of the obturator nerve, which contributes to the popliteal plexus, it is present in 85% of the patients. So this is a very beautiful thing which you have to understand. Like here you can see the compartment, like how important it is to know the exact location of the adductor canal and the femoral triangle block. So neurovascular sheath, it will affect the bulk flow of the drug. Here you can see the femoral artery, specifically superficial femoral artery and superficial femoral vein, along with the saphenous nerve. They are enclosed separately in a neurovascular sheath. So this is the first compartment, which is the subsartorial compartment lying just beneath the sartorius muscle. Then in the second, you can see the lateral compartment, which is present just lateral to the artery, but outside the neurovascular sheath. Within the neurovascular sheath, as I told you, there is vessels along with the saphenous nerve. So always you have to bring the needle within the neurovascular sheath. And how do we confirm it? It is by injecting the drug. The artery, it just gets squeezed in, just like a sunset. And when you stop injecting the drug, artery just bounces back. That's how you can confirm the your needle placement within the neurovascular sheath. And here this orange color line is nothing but the vasoadductor membrane. It is porous. So any drug, local anesthetic, which is present in this sheath, it gets spread from the vasoadductor membrane to involve the subsartorial plexus. Then these are the fascias, two fascias which are covering the vastus medialis muscle and the adductor muscles. And here you can see the important thing, it is that nerve to vastus medialis, which is separated by a fascia covering the lateral compartment, and it is present separately. So just by blocking this, it's not going to block the nerve to vastus medialis. You need a separate injection to block the nerve to vastus medialis. So this is an image I wanted to show where the medial borders of the sartorius and adductor muscles, that joining together to form a namaste sign, or the three sign, or which you call kissing sign. Just proximal 2 to 3 centimeter proximal to this confluence is the distal femoral triangle, where you can see the femoral artery and the femoral vein. Vein is being compressed. Now I have released it, so you can see the vein. Lateral to the artery and the vein is the saphenous nerve, and the nerve to vastus medialis, it lies in a separate compartment. So here you can see the needle trajectory is from the lateral to medial side. So this is the distal femoral triangle block, which is being performed in our institution. So here you can see the needle just lateral to the artery. And in our institution, we do the distal femoral triangle block along bolus dose along with the continuous catheter. So catheter is being placed and the catheter position is being confirmed by injecting the drug. Yeah. So next comes the adductor canal block. It is divided into three parts: proximal, mid, and distal adductor canal. In the proximal adductor canal, proximal third of the adductor canal, just it is 1 to 2 centimeter distal to the apex of the femoral triangle. Its contents of femoral vessels along with saphenous nerve, and it provides sensory block to the anteromedial aspect of the lower leg. You can either give a single bolus or a continuous catheter can be placed, and the volume is around 15 to 20 ml of local anesthetic. Still here, the nerve to vastus medialis, it will lie outside the adductor canal in a separate muscular compartment, so it is to be blocked separately. Then the mid adductor canal, it is the middle third of the adductor canal, just distal to the proximal adductor canal. And distal adductor canal is the lower third of adductor canal, where the femoral vessels, they enter into the adductor hiatus to become the popliteal vessels and they enter the popliteal fossa. No nerves lie in this part of the adductor canal. Then comes the dual subsartorial block. It is a motor sparing, opioid sparing block, which is mainly done with medial incision. It is a hybrid form of subsartorial block where it is combined with two subsartorial blocks, nothing but distal femoral triangle and adductor canal block. It is given immediately after the surgery with two different injections at two different locations, and both are below the sartorius muscle, hence the name dual subsartorial block. So just this is an image showing the differentiation between the distal femoral triangle apex and the proximal adductor canal. So here you can see the distal femoral triangle is where the sartorius muscle, adductor longus, medial adductor magnus muscle medially and laterally by the vastus medialis muscle. You can see the femoral vessels and saphenous nerve, they lie in one sheath, whereas the nerve to vastus medialis is separate. In the apex of the femoral triangle, you will see the sign of 3 or the figure of 3 where the medial borders are meeting together. In the proximal adductor canal is just beneath the apex of the femoral triangle, like 1 to 2 centimeter beneath the apex of the femoral triangle, where you can see the vasoadductor membrane, which is like a bilayered structure visible on the ultrasound. So the nerves mainly blocked in the dual subsartorial block are saphenous nerve, nerve to vastus medialis, and whole subsartorial plexus along with the popliteal plexus and the medial half of peripatellar plexus. Sensory block is to over the anteromedial aspect of the knee up to the tibial tuberosity, along with the medial retinacular complex and intra-articular region. Around 20 to 30 ml of local anesthetic can be injected here. Then comes the hypac block. It is nothing but indirect anterior approach of popliteal sciatic nerve block. So hypac is not that high volume with a low concentration of local anesthetic with or without adjuvant is being injected in the proximal adductor canal just below the vasoadductor membrane. Same thing, nerves are going to block is the popliteal plexus along with saphenous nerve, tibial, common peroneal, which contribute to popliteal plexus and popliteal sciatic nerve. Although this block, it provides analgesic coverage as adductor canal block, but it is mainly described for the below knee surgeries due to wide coverage involving all the innervations below the knee. So these are the some plexus which are present around the knee joint. By performing the distal femoral triangle block and the subsartorial and adductor canal block, you are covering the prepatellar plexus and subsartorial plexus. Then what about the popliteal plexus? This plexus is mainly covered by the IPAC block, which is present in the posterior aspect of the knee. So IPAC block is a motor sparing regional anesthesia. Here, the infiltration of the local anesthetic into the interspace between the popliteal artery and the posterior capsule of the knee. It is always given as an adjunctant to the femoral nerve or any adductor canal block to cover the posterior aspect of the knee. So, It is a selective blockade of the innervation of the posterior knee joint. Target is our popliteal plexus, which is formed by the articular branches of tibial nerve, common peroneal nerve, sciatic nerve, along with the posterior division of the obturator nerve. It travels through a tissue space between the popliteal artery and the femur. This plexus innervates the intra-articular structures and the posterior capsule of the knee. So in this image, you can see the cut section where the femur, just beneath the femur or the popliteal vessels. And so as you can see here, the sonoanatomy. First, this block was proposed by like Sanjay sir. Sir, when he started performing this block, he started by doing the patient in a prone position. The probe it is placed transversely at or just above the popliteal crease to visualize the femoral condyles. As here you can see the two femoral condyles, and the popliteal artery is present at just the center of the scan. So at this level, these femoral condyles, they're appearing as discontinuous curved hyperechoic lines. And you will see the pulsating popliteal artery. So from this point, if the probe is moved cephalot, then keeping the popliteal artery in the view, you will see that this discontinuous interrupted hyperechoic line of these condyles, they change into a continuous hyperechoic structure, which is nothing but the femoral shaft and just cranial to the condyles. Still, you will see the popliteal vessels, and the location of the tibial nerve can be appreciated just superficial to the popliteal artery, and the common peroneal nerve is present late at the lateral edge of the ultrasound scan. And the plane between the popliteal artery and the femur is the space through which these articular branches are traversing, and this is our target site. So here this is another approach where the patient is placed in a supine position with lower extremities being flexed at the knee and abducted at the hip. Here they have placed a pillow like a roll of blankets, something just underneath the thigh. This is known as frog-leg position. To begin the scanning, the transducer it is placed on the lower third of the medial thigh, and we are going to visualize the femur and the femoral vessels in the first image. Then the transducer it is slightly caudally it is slided, observing the femoral artery as it enters the popliteal fossa and continues as like a popliteal artery. So at this point, the transducer it is moved posteriorly and inferiorly to visualize the space between the popliteal artery and the shaft of the femur, with just superior to the femoral condyle. And the needle is always inserted in plane from the medial to the lateral trajectory, keeping the needle parallel to the acoustic shadow of the femur. As you can see in the third image, the needle is very much parallel to the acoustic shadow of the femur, and it is injected from the medial to the lateral side, and the femoral vessels are just present above the femur shaft. With the needle, and the important thing is that the needle tip it should be resting 2 centimeter beyond the lateral border of the artery, and around 20 ml of the local anesthetic can be injected here after negative aspiration. So the main goal of this IPAC is to selectively block only the innervation of the posterior knee joint while sparing the main trunks of tibial, common peroneal nerve. So thereby we are maintaining the sensory motor function of the leg and the foot. So this is the IPAC block, which is performed at institution, where here you can see the needle is being needle trajectory is from the medial to the lateral side, and in plane approach is being performed. So the needle is entering from the medial to the lateral side. I'm sorry, sir.
I would request all the speakers to please stay on the time. Dr. Zeba, if you can
Sir. Yes, sir. I'm
just,
just going ahead.
yeah,
Uh,
please.
Yes, sir. So indications are TKR surgeries, ACL repairs, and procedures that involve posterior aspect of knee. 15 to 20 ml of local anesthetic is used, either 0.2 ropin or 0.25 bupivacaine or levobupivacaine. As I told you, position is like supine or frog-leg position. It is given preoperatively due to the loss of anatomical landmarks after the surgery. So coming to the modified 4-in-1 block, this block was proposed by the Ritesh Roy sir. It is given in the distal adductor canal. The landmark for this block is descending genicular artery. Four nerves are majorly blocked in this block, that is saphenous nerve, obturator nerve, vastus nerve to vastus medialis, and the sciatic nerve. Uh, Here you can see the anterior division of the obturator nerve is also found in the proximal part of the adductor canal, and the posterior division of the obturator nerve is along with the femoral vessel. It enters the popliteal fossa through adductor hiatus. Around 35 ml of 0.2 ropin is injected in this block. It is described to provide analgesia for knee surgeries as well as below knee surgeries. Then there comes the modified 4-in-1 block, which is nothing but it involves two injections. One first injection is around 5 to 7 ml of 0.2 ropin is given just above the vasoadductor membrane after stimulating the nerve to vastus medialis. And then the second injection is given 20 to 25 ml of 0.2 ropin below the vasoadductor membrane perivascularly. So due to the distal spread of this injected local anesthetic through the adductor hiatus, it will enter the popliteal region, thereby blocking the popliteal plexus. So this is a journal where the impact of IPAC when combined with adductor canal block under ultrasound guidance, it's shown on the early motor function. They compared the femoral nerve block along with the superior popliteal sciatic nerve block, which with the IPAC block along with adductor canal block, where this IPAC and adductor canal block showed very mild impact on early motor function. Then this is a systematic review and meta-analysis which was done between the IPAC which added to the adductor canal blocks versus only the adductor canal block in the TKR surgeries, where a combination provided better analgesia than only the adductor canal block, along with decreased morphine consumption, shorter hospital stay, but there was no difference in quadriceps strength or post-op nausea vomiting. And this is another study by the Ritesh Roy sir, where he compared the modified 4-in-1 block versus IPAC plus adductor canal block, where it is being said that modified 4-in-1 block provides the same analgesia as the IPAC and adductor canal block for the post-op analgesia in TKR surgeries. Next comes the local infiltration analgesia. It is intraoperative infiltration of dilute local anesthetic solution to the periarticular soft tissues. So it is because of its simplicity and speed and relative safety, it is recommended by most of the anesthetists as a key part of multimodal analgesia. So this injection is performed by the surgeon mainly at the two stages, one before the component insertion or second after the component, like insertion into the anterior, medial, lateral and the subcutaneous tissues. So the mechanism of action is multifactorial, where it can cause direct sensory blockade, dilution of inflammatory mediators, and direct anti-inflammatory effect. And the main concern here is dose and toxicity of local anesthetic. So this acts as a depot for the ongoing analgesia. The benefits are very nice, like opioid sparing, shorter length of hospital stay. There is high range of motion at 24 hours and good patient satisfaction. But the disadvantages include single shot LIA will have limited duration of analgesia. There is risk of joint infection, chondrotoxicity can occur, and indwelling catheters you cannot put because of fear of infection. And main thing, transient peroneal nerve palsy might lead to femoral foot drop. So the cocktail which is given in our hospital is 0.75 ropin, 20 ml along with ketorolac, morphine 10 mg and magnesium sulfate, which is diluted, made into like 50 ml and being injected by the surgeon. So comparing the IPAC block with periarticular block along with adductor canal block alone, it showed that either IPAC with adductor canal block or periarticular block has better analgesia than adductor canal block alone. So this is a meta-analysis where 170 randomized control trials are being analyzed, which states the pain management modalities after TKR surgeries. Femoral block or sciatic is the best suited modality for the pain management in the post-TKR surgeries. which was done. This is in 2017. Later, the studies have proved the different blocks. So, genicular nerve block. Genicular nerves, there are mainly four genicular nerves: superolateral, medial, inferolateral, and infiromedial. Superolateral genicular nerve is a branch. Superolateral, inferolateral, and infiromedial, they are the branches of the sciatic nerve, except the superomedial genicular nerve, which is a branch of the femoral nerve. So, 3 to 4 ml of local anesthetic is injected. These nerves are difficult to see on the sonoanatomy. So, the landmark here is the genicular arteries. So avoid giving any nerve block, that is inferolateral genicular nerve block, because of its close proximity to the common peroneal nerve, which can cause the foot drop. For chronic pain, you can do radiofrequency ablation as therapeutic measure in the post-TKR patients.
Dr. Zeba, can you please summarize now? It's almost double the time.
Yes, sir. It's done, sir. This is
I would
just the
request everyone to please stick to the.
Zeba, we have two more
last side, sir.
presentation.
The prospect guideline states that single shot adductor canal block administered preoperatively and periarticular local infiltration and analgesia administered intraoperatively are recommended. And this combination of two techniques is also preferred in the prospect guidelines, sir. Yes, sir. Thank you.
Thank you so much for a wonderful presentation. So now for the second talk, you can stop sharing the screen, Zeba.
Answer.
You can stop sharing the screen.
Yes, sir. Thank you, sir.
So second talk we have the RH strategies for total hip replacement by Dr. Sanika Kadam and Dr. Gayatri Karandikar. They both are from Sancheti Hospital, Pune. I would request Dr. Gayatri to please start sharing your screen. Sir, we'll
Yes,
take
sir.
the questions at the end or now, sir? Hetal, sir, Ritesh, sir.
We can take at the end, let the presentation be over.
Okay, sir. So, Dr. Gayatri, please start sharing your screen.
Yes, sir. Okay. Fine. So is the screen visible?
Yeah, but your presentation is not open. You need to open your PowerPoint presentation. We can see your laptop screen.
One second.
Just open the presentation which you want to present.
So we have opened it.
Yeah, we can see your screen. You can make it full screen.
Yes.
Gayatri, kindly stick to your time limits, huh?
Yes. Yes, ma'am. Yes.
Ga-
Okay. Good evening, respected faculty. Extremely sorry for the technical delay. So I am Dr. Sanika Kadam, fellow at Sancheti Hospital, and me and my colleague, Dr. Gayatri, would be discussing the regional anesthesia strategies in hip surgery. So this is a 2026 Lancet study which shows the modern total hip replacements demonstrate exceptional longevity with about 90% of the implants surviving at 30 years. So for this to happen, we require good patient-centric outcomes, which depends upon good post-operative analgesia, early rehabilitation, and good clinical outcome. So this is a video of one of our geriatric patients. He was a 90-year-old patient who was operated for primary hip arthroplasty, and he was mobilized immediately the next day. So discussing the common surgical approaches of the hip, we have three common approaches, that is the anterior, anterolateral, and the direct lateral approach. And the most common approach that we use is the posterior approach, in which the incision is present on the posterolateral aspect of the hip, because this provides excellent surgical exposure. Now, discussing the innervation of the hip. So, the dermatomal, osteotomal, and the myotomal innervation is primarily by nerves of the lumbar and the sacral plexus. We can see that the osteotomal innervation is chiefly by the obturator, femoral, and the sciatic nerve. The myotomal innervation, the hip flexors are again by the nerves of the lumbar plexus, and the hip extensors are by nerves of the sacral plexus. And for the dermatomal innervation, for the anterior aspect, part of the innervation comes from the T10, T11, and T12, which is the ilioinguinal, iliohypogastric nerve, and the rest of it comes from the lumbar and the sacral plexus. So we can see that all of these nerves arise from the lumbosacral plexus, primarily the femoral nerve, the obturator nerve, and the sciatic nerve. So we have a host of different anesthesia strategies for giving anesthesia to these patients. We can either administer general anesthesia or a spinal anesthesia combined with a regional nerve block, or we can give only a regional nerve block. So coming to the regional anesthesia strategies, so the commonly used techniques are the neuraxial blocks, the lumbosacral plexus blocks, and the interfacial plane blocks. So in neuraxial blocks, the most commonly used neuraxial block is again the spinal anesthesia. So we can use, as most of our patients are geriatric patients, we commonly use a low-dose spinal anesthesia, which is 1.4 to 2 ml of heavy bupivacaine with the additive. If we are giving an epidural, the epidural needle is inserted at L1, L2 level, and the catheter tip is present at the T12, T11, T12 level. And for a combined spinal epidural anesthesia, we again give a low dose spinal, that is a 1 or 1.5 ml of heavy bupivacaine, along with a 4 to 6 ml of epidural injection to extend the block. So this is the coming to the paraneuraxial block. This is the lumbosacral plexus block. So here we can see that the lumbar plexus block is being administered using the landmark and the PNS technique. The evoked motor response is the quadriceps contraction, which we can see, and it is at 0.4 milliampere. So after confirming this response, about 20 ml of local anesthetic was given, which was later confirmed by ultrasound. So we have given about 20 ml of local anesthetic for the lumbar plexus block and 10 ml for the sacral plexus, because our primary target was the anterior capsule, which is supplied by nerves of the lumbar plexus. Again, this is a deep block, and therefore we should not give this block in patients who have deranged INR or who have coagulopathies. Now coming to the analgesic blocks, the interfacial plane blocks. So these can be combined with spinal anesthesia or general anesthesia. So briefly discussing the innervation of the hip capsule. The hip capsule is divided into anterior quadrant and the posterior quadrant. With the anterior quadrant has a majority of the mechanoreceptors and the nociceptors, which are concentrated in the superior and the superolateral aspect. And the primary nerves which innervate this quadrant are the femoral nerve, the obturator nerve, and the accessory obturator nerve. The posterior quadrant has mainly mechanoreceptors, which are concentrated in the superolateral aspect, and this is again innervated by the sciatic nerve, nerve quadratus femoris, and the superior and the inferior gluteal nerve. So we can see that the anterior capsule, which has the highest density of nociceptors, would be a primary target of perioperative analgesia. Coming to the applied anatomy, so the femoral nerve divides into high articular and low articular branches depending upon whether they arise from above the inguinal ligament or below. So the high articular branches will pass in the periosteal plane below the iliopsoas tendon and supply all four quadrants of the hip capsule. The low articular branches are present only in 15% of the population and will pass through or inferior to the iliopsoas and supply only the inferolateral quadrant. The obturator nerve again divides into high branches and low branches, and the high branches will originate near the obturator canal and supply the infero-medial quadrant. And the low branches, they arise from the posterior branch and supply the infero-medial or the infero-lateral quadrant. Accessory obturator nerve is present only in 5 to 30% of our population, and if present, it will supply the anteromedial aspect near the iliopubic eminence. So coming to the intrafacial plane blocks, which are the main target is the nerves of the lumbar plexus. So we will be discussing two main blocks, that is the suprainguinal fascia iliaca block, which targets the femoral and the lateral femoral cutaneous nerve, and the pericapsular nerve group block, which targets the articular branches of the femoral nerve, obturator nerve, and accessory obturator nerve if present. So now coming to the first block, that is the suprainguinal fascia iliaca block. So, this block is given in the supine position. We use a high frequency linear probe, and the probe is placed in the parasagittal orientation in the spino-umbilical line, just medial to the ASIS over the AIS. So, what we are able to visualize is this is the lateral orientation marker. This is the sartorius and the deep circumflex iliac artery. Our needle entry is from lateral to medial, and the endpoint is just deep to the deep circumflex iliac artery, so that the fascia iliaca, there is a unzipping of the fascia iliaca. So this block covers the femoral nerve in 100% of the cases and the lateral femoral cutaneous nerve in 80% of the cases. Since this is an interfacial plane block, we give about 20 to 30 ml of local anesthetic, that is 0.2% of ropivacaine is commonly used in our institute. Now, because this block targets the femoral nerve, some patients do complain of quadriceps weakness, and therefore this may delay the post-operative mobilization of these patients. The level of evidence for this block is 1A, and the MEV 95 is 34 ml. This is a systematic review which compares the fascia iliaca block with the control block, and it shows that the FICB significantly reduces the analgesic consumption up to 48 hours. However, it is not effective in reducing post-operative nausea and vomiting, and it also induces post-operative muscle weakness. So now coming to the pericapsular nerve group block. Again, the position of the patient is supine. We can use either a high frequency or a low frequency probe, and this block targets the articular branches of the femoral nerve and the obturator nerve. So we place our probe first on the ASIS and then move it caudally to visualize the AIIS. Once we visualize the AIIS, we move it a little medially so that we visualize the iliopubic eminence, and our needle entry is from lateral to medial, so that the needle endpoint is at the just below the psoas tendon, and the local anesthetic that we give will lift the psoas tendon upwards. So the volume that we give is 15 to 20 ml of dilute local anesthetic, 0.2 to 0.375%. And because this block targets the articular branches of the femoral and the obturator, there is no analgesia present at the incision site, and therefore these patients may complain of some pain. The grade of evidence for this block is 1. So again, this is a systematic review and meta-analysis which compares the PENG group with the control group. And again, they have seen that there was no significant difference in the morphine consumption in the 24-hour period, and also the time for rescue analgesia. But again, to conclude, they have said that PENG block can act as an alternative multimodal analgesia for hip surgery. So now coming to the alternative blocks, this will be discussed by Dr. Gayatri. Thank you.
Good evening. Coming to the alternative blocks. So first we will discuss the quadratus lumborum block. So in this image, we can see the arrangement of the posterior abdominal muscles. This is the lumbar vertebra. Alongside is the psoas major muscle. This is the transverse process. Behind the transverse process is the electrospinae muscle group. And here is the quadratus lumborum. So there are three approaches to the quadratus lumborum. First is the lateral QL, where the drug deposition is in the fascia transversalis, where the quadratus lumborum and the tap muscles meet. Second is the posterior quadratus lumborum, where the drug deposition is just posterior to the quadratus lumborum in the middle thoracolumbar fascia. And anterior QL is where the drug deposition is between the psoas major and the QL quadratus lumborum in the anterior thoracolumbar fascia. Coming to the anterior quadratus lumborum plane block, here the patient's position will be lateral decubitus. We will be using a low frequency curvilinear probe. We will keep the probe between the lower costal margin and iliac crest in the mid-axillary line. And we will see this following this image. This is the vertebral body, a transverse process. In front of the transverse process is the hyperechoic psoas major muscle. Here is the quadratus lumborum, which is a hypoechoic structure, and behind the transverse process is the erector spinae group. So we will be injecting our local anesthetic between quadratus lumborum and the psoas major muscle, about 20 to 30 ml, and this will block the anterior and lateral cutaneous branches from T7 to L1. This is a deeper block, so this should be again avoided in patients who are on anticoagulants, and the level of evidence for this block is grade 1C. Coming to posterior quadratus lumborum block. So in this block, we were depositing the drug just posterior to the quadratus lumborum. Here is the quadratus lumborum, and you can see the drug is getting deposited posterior to the quadratus lumborum. Here in the image, we can also see the peritoneum below. So that shows how deep the block is and the potential risks related to this block. So we will be using a 20 ml local anesthetic for this block. Our needle entry will be from the posterior to anterior. So this article states that a single shot quadratus lumborum block may reduce postoperative pain and opioid consumption after primary THR. Coming to lumbar ESP block. So here the patient's position will be again in the lateral decubitus. We will use a low frequency curvilinear probe in the parasagittal orientation. Needle will be positioned from lateral to medial, and the point of our injection will be between transverse process and erector spinae muscle in the erector spinae plane. We will be giving around 4 to 6 ml of dilute local anesthetic for each level. We can use it as a single level or a multi-level block. And this will block both the dorsal and ventral rami of spinal nerves. So in this image below, we can see the L3 and the L4 transverse processes, and our needle will be coming either from lateral to medial, or we can give it in the out of plane approach as well. So this study compares erector spinae plane block versus the fascia iliaca block after THR. So this study found that there was no statistical significant difference in morphine consumption at 24 hours. However, there was quadriceps weakness which was observed in fascia iliaca plane block, which was preserved in lumbar ESP group. So this article states that for a single shot fascia iliaca block, the recommendation is 1A and the strength is moderate. For a single shot lumbar plexus nerve block, the recommendation is 1B and the strength is moderate. For single shot quadratus lumborum block, the recommendation is 1C, but the strength of recommendation is limited. Even after giving anterior capsular blocks, there is still pain which is observed in around 30% of the patients. That could be because of the posterior capsular pain. So the posterior capsule is innervated by superior and inferior gluteal nerves, sciatic nerve, nerve to quadratus femoris, and cutaneous nerve. So coming to the analgesic blocks for the posterior capsule. So posterior facial plane block. So first is the deep gluteal block, which covers nerve to quadratus femoris, superior gluteal nerve, and the sciatic nerve. Parasacral ischial plane block and infrapiriformis block both will be targeting the sacral plexus. So we will be only discussing the deep gluteal block, where the position is lateral decubitus with hip and knee flexed at 90 degrees. We will be using a low frequency curvilinear probe, where the probe, as we can see in the image, it is kept along the long axis of the femur. And below the image, we can see that the GT femoral neck, head, and the posterior acetabular rim are visualized in a single plane, and above which lies the piriformis muscle. So our drug deposition will be deep to the piriformis. So needle entry will be from posterolateral to anteromedial. and we will be giving around 20 ml of 0.2% ropivacaine. So this editorial states that there was a study conducted by Hu et al. So they gave a PENG block along with deep gluteal block along with local infiltration, and they found that this combination provided a satisfactory analgesia, and the patients recovered faster. But the independent study for deep gluteal blocks has not been done. Coming to the prospect guidelines. They state that preoperatively, paracetamol along with NSAIDs or COX-2 inhibitor should be administered. Spinal anesthesia should be given with intrathecal morphine of 0.1 milligrams, and IV dexamethasone of 8 to 10 milligrams also should be administered. Postoperatively, a single shot Stiffy block or local infiltration should be given, and opioids should be used as rescue analgesics. So this meta-analysis was conducted and 87 RCTs were included in this. So they found that at 6 hours post-surgery in static VAS score, the femoral nerve block was found to be superior compared to the lumbar plexus block with local infiltration. In dynamic VAS, at 6 hours, PENG with local infiltration was found to be superior. And at 24 hours, the morphine consumption was found to be the lowest in quadratus lumborum plane block with fascia iliaca block. So they have concluded in their study that a combined regional anesthesia modalities, particularly PENG block along with the LIA, was found to be a favorable option. This particular study was conducted at our institute where patients were divided into 3 groups. PENG block was common to all groups, and we have given SIFI, LESP, and PQLB in 3 different groups. So in the first diagram, we can see the NRS pain scores were compared, and we found that at 12 hours post-surgery, the SIFI plus PENG group had the lowest pain scores, and LESP with PENG had the highest pain scores at 8 hours. In the next image, we can see that the total 24-hour opioid consumption was found to be the lowest in SIFI plus PENG group. But at the same time, the quadriceps weakness was also observed in this group, which was prevent in LESP with PENG group. So we found that PQLB with PENG is a more balanced block as it provided prolonged analgesia, it provided opioid sparing, and also the quadriceps strength was preserved. So this particular study was done for a very high risk severe aortic stenosis patient who had pulmonary comorbidities as well. So this study group has administered a lumbar erector spinae plane block along with anterior quadratus lumborum block, and they found that they could provide satisfactory anesthesia for such a high risk case. So to conclude that we know that no single nerve block can cover all the nerves, but the nerves paired in one block can be covered in the another block. So a combination of interfacial plane blocks, it will provide better analgesia for total hip surgeries. Thank you very much.
Thank you, Dr. Sanika and Dr. Gayatri. Ritesh sir, Vipin sir, should we finish the last talk also and then take the questions?
Yes, finish it.
Okay.
It's almost the
Okay.
same topic, so we can
Yes,
finish
sir.
it.
So for the last talk, it's on a journal club presentation on iliopsoas plane block for hip arthroplasty. I would like to request Dr. Sridevi to please start your talk. You can share your screen. And I would request all the fellows to put your questions in the chat box so that can be taken at the end.
Is it visible, sir?
Yes.
So the topic is analgesic effect of iliopsoas plane block for hip arthroplasty. So iliopsoas plane block is a recently developed motor sparing regional technique, and the targets are articular branches of the hip joint, that is sensory branch of the femoral nerve and accessory obturator nerve. The femoral nerve, accessory obturator nerve, and obturator nerve collectively dominate the sensation of the anterior capsule of the hip joint, which has maximum nociception. So in a study which has shown that the postoperative pain relief could not be achieved by obturator nerve block alone. It's a study by Nielsen et al. Published in 2019 in RAPM, which says that the obturator nerve block alone does not alleviate the postoperative pain after total hip arthroplasty. So the principal analgesic targets for the hip joint are the femoral nerve and the accessory obturator nerve. So this is a study published in the year 2022 by Shang et al., which compares between the PENG block and the iliopsoas plane block. It says that the PENG block can cause 25% or more quadriceps weakness, while iliopsoas plane block can preserve quadriceps strength. And the applied anatomy says about iliopsoas complex. It is a muscle in a musculocutaneous muscle. Iliopsoas muscle is a musculotendinous origin. It's a unit which has origin superiorly from the lumbar vertebrae and iliac crest, and it is inserted inferiorly to the lesser trochanter and infratrochanteric ridge. Between the lower portion of the iliac ala and the femoral neck, 4 major components can be observed in the transverse section. Lateral muscle fibers of the iliacus, medial muscle fibers of the iliacus, iliopsoas tendon, and psoas major muscle tendon. So iliopsoas tendon is a conjoint tendon fused by the lateral psoas major tendon and the medial iliacus tendon. From AIIS going caudally, we can see an iliacus minor muscle. It is also known as the ilio-infratrochanteric or iliocapsular muscle. It appears deep and then lateral to the iliopsoas complex. It is different from the iliopsoas complex and it is originated from the anteromedial hip capsule and the inferior border of the AIIS. And iliopsoas plane is a plane where we see the spread of the injectate after iliopsoas plane block. Its anteromedial wall is formed by the extrapelvic part of the iliopsoas muscle, and posterolateral wall is formed. It is divided into a cranial part and caudal part by AIIS. Cranial to AIIS, the posterolateral wall is formed by the iliac ala, and caudally it is formed by the iliacus minor muscle and iliofemoral ligament. And we have 3 different iliopsoas plane: osseous, ligamentous, and muscular. Osseous plane is a facial plane between the iliopsoas complex and the iliac corpus that cranially extends through the iliac ala to the iliac crest, bounded laterally by AIIS and medially by iliopectineal eminence. And ligamental iliopsoas plane is defined as an inverted triangle-shaped facial plane between the iliopsoas complex and the capsular ligament of the hip, and is bounded laterally by iliacus minor muscle and medially by the iliopsoas tendon with the iliopectineal bursa. And muscular iliopsoas plane is a facial plane between the iliopsoas complex and laterally associated iliacus minor muscle. And the needle tip position for this block lies at the junction of the muscular and the ligamental iliopsoas plane. Here in this picture A shows at the level between the AIIS and ASIS. The posterolateral wall of this iliopsoas plane, is marked as a dark green color, and the posterolateral wall is seen osseous completely, which is formed by the iliac ala, and the anteromedial wall is formed by lateral fibers of the iliacus and medial fibers of the iliacus. And in the image B, which is at the level of the PENG block, it is seen at the level of the iliopectineal eminence. Here we can see an orange color muscle emerging, which is the iliacus minor muscle, and here the iliopsoas plane is divided into a muscular and an osseous part. Muscular part is between the iliacus minor muscle and the lateral fibers of the iliacus, and the osseous part is formed by the corpus of the ilia. And image C is at the level where we inject the drug for the iliopsoas plane block. Here we can see the emerging of the capsular ligament of the hip, and it replaces the osseous part of the posterolateral wall. And here iliacus minor become bigger and making the muscular iliopsoas plane more vertical. Now the iliopsoas plane become an L shape. In image D, it is at the level where the femoral head transits into the neck of the femur. And here also the iliopsoas plane remain as an L shape, but here ligamentous iliopsoas plane becomes smaller. And this arrow shows the point of injection where between the muscular and the ligamentous iliopsoas plane, where we are injecting drug for the iliopsoas plane block. So this image shows the spread of the drug after iliopsoas plane block, and the solid arrow represents the route in Nielsen et al.'s volunteer study, and the faded line represents the theoretical spread if we increase the volume. And the predominant spread, that is 100% spread, is seen along the L-shaped iliopsoas plane. If we increase the volume, we can see the lateral facial plane spreading between the iliacus minor muscle and capsular ligament, and medial facial plane is spreading into the iliopectineal bursa. And also there is an intermuscular spread between the lateral fibers and the medial fibers of the iliacus. And they concluded by saying that the PENG block and the iliopsoas plane block are 2 highly similar ultrasound guided interfacial plane block for analgesia of the anterior hip capsule, but they differ in the final needle tip position and the volume.
PENG block places a tip directly deep to the iliopsoas tendon and may end up as an iliopectineal bursal injection, maybe due to volume overload or pressure overload or direct bursal puncture. And trials have shown that PENG block can result in 25% or more of quadriceps weakness postoperatively. But iliopsoas plain block, its needle tip is lateral to the iliopsoas tendon and inject is just 1/4 of the PENG block's injection. And the spread here has been shown to be restricted inside the plane within a well-defined L-shaped channel bounded laterally by the iliacus minor muscle, medially by the iliopsoas tendon and the iliopectineal bursa. And they recommended that the PENG block is indicated in clinical scenarios where the post-procedure quadriceps weakness is not an immediate concern, as in on-arrival block for femoral neck fracture in emergency room. And the iliopsoas plain block is indicated when intact motor function of the quadriceps are required. That is during early mobilization following ERAS protocol after total hip arthroplasty. This is the image of a PENG, which is taken from our institute. It's an image where we are giving injection for PENG block. This, I hope you can see this. It shows a iliopsoas tendon, iliopectineal eminence, lateral to the, we are injecting the drug below the iliopsoas tendon. This is an image for the iliopsoas plain block. Here we can see the iliopsoas tendon, the capsule of the hip joint, and this is the L-shaped between the iliacus minor muscle and the iliopsoas muscle, spread of the drug. Next is an article published in the year 2019 by Nielsen et al. He says that the iliopsoas plain block does not cause motor blockade. It is one of the pioneer study. It is a randomized volunteer trial. Before this study, he has published another cadaveric study where 5 ml of the dye is injected in the iliopsoas plane and observed the spread throughout the iliopsoas plane to all the sensory branches of the femoral nerve, innervating the hip joint. So this is a randomized volunteer study. Its aim is to assess whether it causes motor blockade in live subject and to assess the pattern of the injected spread in the subject using MRI. It is a double-blind randomized volunteer trial with a sample size of 20. Healthy volunteers of more than 18 years, ASA 1 and 2 are included. Baseline motor isometric knee extension and isometric hip adduction and sensory tests were done to compare with the baseline. Nerve blocks were performed by a single regional anesthesia expert to avoid the bias. A curvilinear 2 to 5 megahertz transducer is used. It is oriented in a transverse plane just caudal to ASIS. If the transducer is then rotated 20 to 30 degrees counterclockwise on the right side and clockwise on the left side, and then it is shifted parallelly along the inguinal ligament till we see the hip joint, where the head of femur dives deep to the acetabular. And a 22 gauge needle, nerve block needle is advanced from in plane technique from lateral side until the tip of the needle is located in an iliopsoas plane between the iliopsoas muscle and the iliofemoral ligament just lateral to the iliopsoas tendon. 5 ml of the lignocaine 1.8% mixed with contrast is used. It is injected into either left or right side, and a sham injection containing 5 ml of the contrast alone was administered on the contralateral side. After the injection, MRI scanning was done to assess the spread of the drug, and sensory and motor testing was repeated 1 hour after the nerve block. Maximum isometric force of bilateral knee extension and force of hip adduction before and 1 hour post block are compared. The result is the mean difference of maximum force of knee extension between the baseline and 1 hour after the block was minus 9.7 with a p-value of 0.12, which is statistically insignificant. And mean pair difference between the active and sham is minus 8.1 Newton with a p-value of 0.12, which is also statistically insignificant. Thus, the size of the statistically insignificant mean reduction from baseline to 1 hour after iliopsoas plain block was just 2.7%. Here, the maximum force of hip adduction from baseline to 1 hour after the block was 0.75 Newton and with a p-value of 0.91, and the pair difference between the active and sham is 3.3 Newton with a p-value of 0.53. Both are statistically insignificant. Here, the right, this side shows the active side and the other one is the placebo side. We are comparing the baseline with the post block. In the active side, we can see the isometric force remains same after the post block with very, very little difference in the muscle strength. If it is very much, there is an increased reduction in the strength. It is compared with the placebo side. And spread inside the iliopsoas plane is seen in 100% of all this, in 100%. Spread between the iliopsoas muscle and the iliofemoral ligament is seen in 33%. Spread to the iliopectineal bursa is seen in 28%. Medial spread between the pectineus and external obturator is not seen in any of the subject. Superficial spread to the superficial surface of the iliopsoas muscle is seen in 5%. Intra-articular spread deep to the hip joint is seen in 5%, and deep spread posterior to the hip joint is not seen in any of the subject. This is a transverse T1 weighted MRI slices of a single subject, and most proximal slide is 55 millimeters proximal to the greater trochanter, and the distance between each slice is 13 millimeter. Here also we can see an L-shaped spread of the dye through an iliopsoas plane, with medially it is restricted by an iliopsoas tendon. In all the subjects, the dye spread through the iliopsoas muscle between the iliacus minor muscle with the tendon of the rectus femoris muscle and medial fibers of the iliopsoas muscle. The medial spread was limited by the iliopsoas tendon in most cases. So they concluded that there is no statistically or clinically significant reduction of the force of knee extension or adduction due to iliopsoas plane block. The block resulted in spread of the injected throughout the plane, which contain all the sensory fibers of the femoral nerve innervating the hip joint. This study is published in the year 2025 by Janchen et al. It shows the ultrasound guided iliopsoas plane block with LFCN block for postoperative analgesia in hip arthroplasty. It is a case series which contained 10 patients whom underwent hip replacement surgery. So before GA, ultrasound guided iliopsoas plane block and LFCN block were given with 10 ml and 5 ml of 0.375% and 5 mg dexamethasone each. After giving gen block, the effectiveness of the block was evaluated. And sensory block is graded as grade 0, no blockade. Grade 1 is reduced sensation to cold stimulation. Grade 2 is tingling sensation, but there is no sensation to cold. Grade 3 is no sensation to both cold or pinprick. And sensory blockade level reaches or exceeds grade 2 is considered as an effective block. If it is not achieved within 20 minutes, the subject is excluded. And postoperative analgesia and quadriceps muscle strength is tested by NRS and quadriceps manual muscle test at the time of the discharge from PACU, 2 hour, 4 hour, 6 hour, 12, 24, and 48 hours postoperatively. The MMT is graded as 0 is no muscle contraction, 1 is slight contraction with no joint movement, 2 is horizontal movement but there is no resisting against gravity, 3 is able to fight against gravity but not against resistance, 4 is able to fight gravity with some resistance, and 5 is able to fight against gravity with sufficient resistance. And the result is all patients maintained a static NRS score of less than 2 and a dynamic NRS score of less than or equal to 3 during the 48 hours postoperative period. Here we can see the NRS score at rest and dynamic. So we can see all the subjects have a score of 1 or less than 1 or 2 in at rest and 1 or less than 3 in dynamic state. And the opioid consumption at 48 hours is almost 0 for all the subjects. Here the MMT grades after surgery shows it's either 4 or grade 5, and after 4 hours all the subjects have grade 5 grading. And analgesic satisfaction is 9 for all the patient, and postoperative stay is average of 6 days, and there is no recorded case of in-hospital fall, nausea, vomiting, respiratory depression, nerve injury, vascular injury, or infection. So they concluded that iliopsoas plane block combined with LFCN provides sufficient and complete analgesia for hip replacement while avoiding the postoperative opioid. When it is combined with LFCN, it was effective in preserving the motor ability and promotes early rehabilitation. This is a study published in the year 2023 by Wang et al. It is a randomized controlled trial of iliopsoas plane block versus femoral nerve block for hip arthroplasty. So the aim is to compare between the iliopsoas plane block and femoral nerve block in patients undergoing hip arthroplasty in terms of pain management, morphine consumption, and early rehabilitation. It is an RCT including 90 patients scheduled for unilateral primary posterior approach hip arthroplasty. Patients were randomly assigned to either iliopsoas plane block or femoral nerve group in a 1:1 ratio based on a computer-generated randomization sequence. No significant differences in the patient characteristics between the two groups. So USG guided iliopsoas plane block was performed with 10 ml of 0.5% ropin, and femoral nerve block was performed with 10 ml of 0.5 ropin. And LFCN block was performed with 5 ml 0.5 in both the groups. And all the blocks were performed by same anesthetist. Following blocks, GA was given to all the patients. So the primary outcome is to analyze the pain score during hip flexion and 4 hour post-surgery. And secondary outcome is the quadriceps strength and pain scores upon our arrival in the PACU, and at 2, 4, 6, 24, 48 hours post-surgery, total opioid consumption, patient satisfaction, and complication. So when comparing between the iliopsoas plain block and the femoral nerve block, the pain score during the flexion of hip at 4 hours is 1 for both the group, and at arrival at PACU 2 hour 4, 6, 24 and 48 is 0 for both the groups during rest, and during flexion also 1 is that it is comparable between the two groups. When quadriceps strength is tested between the two groups, for all the subjects in iliopsoas plain block, they have maintained a strength of 4 and 5. But in femoral nerve block, patient had quadriceps weakness, which returned to normal after 48 hours. Total opioid consumption is comparable between the two groups. So there is no significant differences found between the iliopsoas plain group and the femoral nerve group in terms of analgesia, opioid consumption, patient satisfaction, and complication. And they concluded by saying that there is no significant superiority of iliopsoas plain block over femoral nerve block in terms of postoperative analgesia following hip arthroplasty. But iliopsoas plain block has an advantage in terms of motor sparing, which may facilitate early recovery and rehabilitation for the patients. Thank you.
Thank you, Dr. Sridevi, for your talk. I would like to welcome Dr. Amit Dixit, sir. Sir joined a little late. Welcome, sir. And I would request all the three moderators, Amit sir, Ritesh sir, and Vipin sir, to take the questions now. There are no questions in the chat box as such.
Dr. Zeba,
Yes, sir.
what are the, you told after dissection, what are the structures, nociceptors which are left? You told only posterior capsule. Is it so?
Like cruciate ligaments are removed, so collateral ligaments are left out along with posterior capsule. Menisci are removed.
Viral, can I just share my one slide?
Yes, sir.
Can I share
Yes,
my
sir.
screen?
Yes, sir.
Okay. Okay. Is it visible?
Yes, sir. You can make it full screen.
Just a minute. Is it visible now?
Yes, sir.
So basically, this is the innervation and the nociceptor density, okay, which is left pre-TKR, okay. And if you see, you have the highest nociceptors in the anterior capsule, the proximal part of the posterior capsule, the meniscal horns, and the medial and lateral retinaculum, okay. And post-surgery, post-TKR, these are the innervations, nociceptors which are left, okay. So your ACL is totally removed as you told. PCL, some surgeons keep it, okay, because you have the proprioceptors mainly in the PCL. So depending upon the how healthy is the PCL, they decide to keep it, but many surgeons remove it. So what is left is the main nociceptors are mainly the incision, the anterior capsule, the proximal part of the posterior capsule, and the medial and lateral retinaculum. Okay?
Yes,
So
sir.
you can just keep, all the fellows, you can just keep a snapshot of this two slides. What is pre-TKR, what are the nociceptors, and what is the post-TKR nociceptors, and what is the innervations of those nociceptors. Okay.
Okay, sir.
Okay. Now, what is the none of the speakers mentioned about multi-modal analgesia. That is one of the most important part of a post-operative pain management, right?
Yes, sir.
So what is the regimen which you follow in your hospital of TKR?
Sir, we follow a subarachnoid block with distal femoral triangle along with a continuous catheter, along with IPAC block, sir.
Okay. Any other? No multimodal?
Sir,
You have to-
along with in a post-op, we plan like IV analgesics, sir, 1 gram paracetamol, along with if creatinine is normal, we give IV diclofenac 75 mg. If required, we also start tramadol, sir.
Okay.
Good evening, sir. I'm Dr. Vinay, consultant from Apollo. We
Yeah,
do
please tell
give
me.
ketamine. We do give ketamine 20 milligram intraoperatively,
Hmm.
and LIA is injected with ketorolac, magnesium, and ropivacaine, sir.
Okay. You give IPAC and LIA both.
Yes, sir.
Yes, sir.
Okay. Okay, fine. Okay. Okay. Amit, over to you.
Yeah, so thank you, Ritesh, for covering me. We have Durandar examiners like Vipin and Ritesh. So I'm really, it's a very strong panel. So I have one question for, because this is how we proceed with any exam. So Sanika and Gayatri, I've seen your presentation also. So suppose you have a patient who has got an ejection fraction, a 60-year-old gentleman with ejection fraction of 20 to 25 percentage, with diabetes and hypertension. This is a common case with IT fracture coming to you. Could you just tell me what is your anesthesia care plan for this patient?
Sir, a single shot spinal anesthesia with low dose, approximately 1.5 to 2 ml of heavy bupivacaine. And for the post-operative analgesia, we would be administering a CFE block along with the PENG block.
Gayatri, you have not listened to the question nicely. He has mentioned something about the
Yes, sir.
ejection
Yes, sir.
fraction.
Sorry. The ejection
So,
fraction is very low. Yes.
so with a 20-25 ejection fraction, are you going to go for a
No, no, no.
spinal?
No, sir. No,
Then,
sir.
then you should listen to the question clearly. So now
Sorry, sir.
now I have made it clear. Now say, now answer to his question. What's your plan?
Patient, we can administer general anesthesia along with a preoperative CFE block along with a PENG block. So for CFE block, we would be giving about 20 to 30 ml of local anesthetic,
No,
and
why
for the PENG,
general anesthesia? Why general anesthesia?
sir, because the
Not really.
ejection fraction of this patient is low, so we would like to avoid the hemodynamic alterations that could occur in this patient.
All right. So what regional options you have?
So for
We
regional
do,
options, we can give a combined spinal epidural using a very low dose of spinal anesthesia. That is, in our institute, we have given about 1 to 1.5 ml of heavy bupivacaine, and then a graded epidural dose. That is, for initially we can give about 5 to 6 ml of
no,
epidural
I
top up
got it. I
depending.
got it.
Okay.
Then if you are saying low dose spinal and epidural, then why you mentioned GA as your first choice? I mean, this could have been the first answer, or is there any
Yes,
advantage
sir.
with general anesthesia? What is your choice? Like,
The general anesthesia has the only advantage that we avoid the hemodynamic alterations that can take place. So epidural anesthesia, if we give, we sometimes there is, even with an epidural, there is
no,
a risk of
I got it. I
hypotension in
got
these
it.
patients.
The purpose of asking this question is during exam, we'll be asking the similar questions. So
Yes, sir.
you have to think a bit about the question itself and then try to answer. Suppose if I make, uh, say, this was because this is a very common question which we ask, and most of the time people will answer those. The answer content of the answer is that which they never practice. So the purpose of asking this question is you have to be very logical what you do routinely in your practice. You have to tell. So anybody would say very low dose spinal and epidural, which you defended very well when I asked you the advantages, disadvantages. So but that should come up with you as your answer. Suppose if you say no, I will do continuous spinal anesthesia for this patient, or you mention I'll do it under lumbar and sacral plexus block only. So this is in the exam, it's okay, you can answer this, but is this the commonest method which you practice? Or you have any specific advantage in this specific, say, patient has coagulation issue, so I would not like to do central neuroaxial. Or, it's a level 3 block. I'm not good in lumbar sacral plexus, so I would like to do a level 1 block, something like spinal epidural. So you have to defend. So what we have seen with many of our students is they try to tell those things which they have never practiced or never seen. So do not, we are
Yes.
not here to assess your memory function or how much you have read, or just because this is regional anesthesia, it does not mean that you should compromise safety of your patients. So you should come up with a very, I mean, you have answered it well, no doubt about it. But, and this is of course a webinar, so webinar is even more stressful. I have seen your presentation and other things also, so that's not a problem. I'm just not to you, but in general, I'm letting everyone know that we want our students to answer what they practice, and if further asked, they can tell other methods also, and then we can have other discussions about complications and other things. So this is how the exam will start. So I have seen somebody telling very complicated block just because it is regional anesthesia exam. That is not right. And when we talk about such critically ill patient, probably it is good idea to highlight more on the monitoring aspect first. Like I would like to secure a arterial line for this patient, make sure that I have all the necessary helping hands, inotropic support, central and other things. So we are here to assess how safe you are. So it is worthwhile that you emphasize more on the safety aspect as well before you embark on any regional technique. So you would like to risk stratify this patient. So not we are not going for a basic MD viva or something, but little bit about risk stratification, and then you proceed. So possible options, and then you can move on. So this is one point. Rest is you have read well, you have prepared well. So I'm asking you, suppose you have done a peng block and patient is after surgery, it was say surgery done under general anesthesia, and you have done a peng block for postoperative analgesia. And after surgery, say patient is buckling at knee level, and there is little extension problem with extension of knee. What has gone wrong with the patient post surgery? Knee buckling.
So, sir, so there could be some quadriceps weakness because of that the patient is having those problems. So there is a possibility, sir, that while the injection was being made, the drug has like spilled over the ASIS and gone to the femoral nerve. So maybe because of that the patient is experiencing this complaint.
Correct. So
Where do
we will
you
not. Yeah.
where
Yes.
do you
Yes.
ideally place your needle for a peng block, Gayatri?
Sir, the needle is placed just posterior to the psoas tendon, and
Uh,
we will be
what is there posterior to this vast tendon?
so the articular branches of femoral and obturator nerve,
What is
and
there posterior? What is there posterior to this vast tendon? Is it you place the needle posterior to this vast tendon or lateral to this vast tendon?
sir, the needle placement is between the AIS and the iliopubic eminence, just lateral to the psoas tendon. Because if the needle
Yes.
progresses further, then the drug could spill over to the femoral nerve, and then again there can be quadriceps weakness.
Usually you have a idiopectinal bursa which lies just below the psoas tendon. That's why you should not place your needle below the psoas tendon. You should be lateral to the psoas
Lateral to
tendon.
psoas.
Yeah, and how will you confirm that your needle is in the right plane?
Sir, we will see that the psoas tendon is getting lifted up from
And
this.
have you appreciated some fascia lifting up? You're right, the psoas tendon starts lifting up. You have done pen block. You must have done it, obviously. So do you have marked anything lifting up when you are injecting, when your drug is in the right plane? Have you appreciated a fascia, thin, white, hyperechoic fascia lifting up when you start, if your drug is in the right plane? Have you marked that?
Probably we were not able to appreciate it.
Okay. Yeah, okay. Next time when you are performing, just mark it. You can appreciate a hyperechoic fascia just lifting up along psoas tendon lifts up, but you can appreciate a fascia lifting up. Okay?
Okay, sir. Okay, sir. Yes, sir. We'll
Okay.
definitely
Yeah.
look into it.
Weapon.
Yes, sir. Sir, I have a question with Jeba. Jeba?
Sir? Yes, sir.
Yeah. Your presentation was good, and as Adam sir told that if videos are not like you should not make with the phone, you should have taken it through the machine itself by using pen drive or something. Then it will look better.
Yes, sir.
No,
Sorry about that, sir.
in none
It
of
was
the videos you have shown the block how it has been performed. All videos you have shown just the anatomy you have told, and like sunset sign you have told, but you have not shown it. You have just show the medial and the lateral border of the rectal canal. None of the
yes, sir.
videos shown the drug spread and the needle is reaching that nerve. Okay.
Sorry about
So
that, sir.
later next
Next
time you have
time.
shown, if you are showing the block, that means you have to show the drug spread also, and you have shown the nerves also in the video.
Okay, sir.
And video quality should be better.
Okay, sir.
Okay. Second question is like you told, by giving this rectal canal block, you are blocking the prepatellar plexus.
Yes, sir.
Can you explain where the prepatellar plexus exists, and what is the role of prepatellar plexus in the TKR?
Prepatellar plexus, it is present around the patella, sir. And the contributing
Where?
nerves, like around the
It's in
patella.
the cutaneous subcutaneous level. It is at the adductor canal level. It is at the muscular level. Where it is
At,
exactly present?
at the adductor canal level, sir.
At the adductor. Are you sure? It is in the adductor canal, prepatellar plexus.
No, sir.
Where it is?
Distal to the adductor canal, sir, where this medial femoral, intermediate, and lateral femoral cutaneous nerve, along with the saphenous nerve,
Are they in the adductor canal? All these nerves are in adductor canal?
No, sir. They are like a distal femoral triangle. You'll find this now, sir, just in the femoral triangle.
In the femoral triangle, you will find distal femoral triangle. You will find cutaneous nerves.
So cutaneous nerves are exited initially, sir, just in the femoral triangle, like proximally.
The proximal femoral triangle.
Yes, sir, proximal
So you won't
femoral
find
triangle.
into the distal femoral triangle.
No.
Okay. So first is it is not in the adductor canal, not in the distal femoral triangle. Okay.
Yes,
and
sir.
then peripatellar plexus is present where? It is present in the just proximal to the knee or patella in the subcutaneous level, not at the
Okay,
adductor
sir.
canal level.
Okay, sir.
Right? Because
Okay, sir.
nerves are going, so cutaneous nerves are going above the sartorius or below the sartorius?
They're going like above the sartorius, sir.
Above the sartorius. So will your block, you are performing adductor canal or femoral triangle block with the femoral triangle block where you are giving? Proximal or distal?
Sir, distal femoral triangle block, sir.
So distal femoral triangle you are giving, right? So distal femoral triangle will, how much volume you have not mentioned even, like in femoral triangle, what volume you have used?
Sir,
Adductor
10
canal
ml.
you have told, but femoral triangle you have not told.
Okay.
How much volume?
10 ml of bolus dose will be given, sir. Then after inserting catheter in post-op, we'll connect with the 0.2 ropin at the rate of 5 ml per hour for 48 hours, sir.
10 ml, given into the femoral triangle.
Yes, sir. Femoral triangle. 10 ml of bolus dose will be given, sir. 0.2 or 0.25 levobupivacaine, sir.
So if you give into the distal femoral triangle 10 ml, so maybe 5-6 ml will reach the proximal femoral triangle.
Yes, sir.
And chances are that it can block.
Block, sir.
Right?
Yes, sir.
Maybe.
Yes, sir.
But you are not sure. Have you ever faced that after giving femoral triangle block, patient complains of incisional pain?
Yes, sir. In post-op, a few patients have seen, sir, where then we have to give the IV analgesics and manage with the giving bolus dose. There
But
can
you are
be
telling
the
your
chance
adductor
of
canal is also blocking the prepatellar plexus. You told in your presentation, adductor canal content prepatellar plexus is getting blocked.
okay.
So where you should block the cutaneous supply? What are the medial cutaneous and lateral cutaneous? How you can block it? At which level and at how? You know? Have you read about it?
Yes, sir. They can be blocked in the proximal femoral triangle, sir.
How? Where?
It's like I'm not very sure, sir.
So either you have to block into the femoral triangle, either distal femoral also above the sartorius, between the two layers of fascia lata.
Yes, sir.
You see above the sartorius there is a fascia lata. Either you have to deposit the drug there to block the cutaneous nerve,
Yes, sir.
or you can block it into the adductor canal also. Just giving the drug above the sartorius, same and the same plane between the two fascia lata for
Okay,
the
sir.
cutaneous nerve. So next time whenever the patient complains any cutaneous pain, just say this and
Yes,
see
sir.
whether patient get relieved or not.
Okay, sir.
Okay, and read
Okay.
about prepatellar plexus, where it is present and how it is working.
Yes, sir.
Okay.
Okay, sir.
So next is you told we are giving LIA and IPAC both.
Yes, sir.
Why?
LIA is given by the surgeon, sir, and IPAC
No, but is there any role if you are giving LIA and IPAC together?
For the better post-op anesthesia, sir.
Like why you are like LIA is targeting which nerves and IPAC is targeting almost same, like what is the
Yes.
difference why you are giving both if they are targeting the same?
Or we can reframe
Hello,
the
sir.
question. What is
Hello, sir. I'm Dr. Vinay from Apollo.
Yes, sir.
Our surgeons don't want to infiltrate in the posterior capsule in LIAS.
That is okay, sir. In LIA, you
They
are
don't
not
inject into
infiltrating
posterior
posterior
surface.
capsule. Okay.
They inject only patellar and lateral, medial lateral. They don't inject posteriorly. That's why we give IPAC.
Okay, IPAC you gave pre-op or post-op?
Pre-op
Pre-op
only.
only. Okay, and then you are giving this. Okay, sir. Sure. Then okay.
Seba, I have a question.
Yes, sir.
You mentioned what is the concentration your surgeon uses for LIA?
Yes, sir.
Because you have mentioned, I think, 0.75% 20 ml,
Yes,
right?
sir. Sir.
Right?
Yes,
And
sir.
already you are giving a IPAC, you are giving a distal femoral triangle block.
Yes, sir.
Is it not the dose? Are you exceeding the dose? Just a query.
Yes,
Just a
sir.
query.
Like we calculate, sir, toxic dose of local anesthetic before injecting, sir. 0.25 levoanavin we use for distal femoral triangle block, sir. 10 ml, 8 to 10 ml as a bolus dose, and 15 to 20 ml of IPAC block with 0.2 ropin.
Yeah.
These are the concentrations which are used, and within the toxic dose, we plan to give the block, sir.
Okay. Because why I asked
Yes, sir.
seeing the concentration, because for surgeon it doesn't matter what is concentration, they will start
Exactly, sir.
injecting. For them, volume doesn't matter. Ultimately, if anything we land in a problem, we have to manage it. Fine.
Yes,
Okay.
sir.
Okay. Thank you.
Thank
So
you,
you
sir.
are telling you are giving paracetamol also, ketorolac also, tramadol also, like.
Sir, it
Or
is like
tramadol
a
is SOS?
tramadol is SYS, sir. First, like paracetamol 1 gram IV TID is added, sir. Followed by, if creatinine is good, then within limits, then diclofenac will be added. Tramadol is SYS, sir, if the pain is unbearable.
Okay, correct. Okay, sir. So any other question on this adductor canal?
No, I'm done. Thank you.
So
Thank
there
you.
is a
Nice
question in
presentation, all of
the
you.
so there is a
Thank you.
question in the chat box. What's the best block or combination of blocks for unicondylar arthroplasty? By Dr. Anshuman, sir.
Zeba,
See, you,
Mm, So you can give adductor canal block with IPAC block.
Jeba, what is the volume of the adductor canal?
So it is just 8 to 10, like 8 to 10 centimeters is its length, sir.
How much volume they have told?
Effective volume is around 10 to 15 ml, sir.
So roughly 10 to 12 ml they have mentioned in the literature. A volume of adductor canal is 10 to 12 ml.
Okay,
So if
sir.
you are giving 20 ml or 25 ml in the adductor canal, what will happen to the drug?
So drug will sweep down proximally and caudally, sir.
Okay.
It will sweep down into the popliteal fossa and eventually it will block the popliteal plexus. It can go ahead cranially also, sir.
So giving 20 ml in adductor canal and then giving IPAC also 25 ml. So IPAC is also blocking the popliteal plexus.
Hmm.
And your 25 ml drug is also after 10 12 ml of volume, adductor canal volume, balance remaining 10 to 12 ml drug will reach to the popliteal plexus also.
Hmm.
Huh? And
Yes, sir.
recently, when Sandeep Diwan sir has published one cadaveric study in which, though it is a small cadaver, like 2 3 cadavers only, but
Okay.
he has shown that even now to vastus medialis is getting stained with the dye into the adductor canal. Though
Okay,
he has
sir.
used only 8 to 10 ml, but if you use 20 ml, you can imagine how much drug will reach proximally also up to which level in the adductor canal. Like
Hmm.
if you give mid or distal adductor canal of 20 ml,
Hmm.
the drug can go cranially up to what level if the volume of the adductor canal itself is only 10 to 12 ml.
Hmm.
Hmm?
Okay, sir. Okay, sir.
So just think about it and just maybe you can think of further exploring the study.
Yes,
So
sir.
I have a question for Dr. Gayatri and what other person for who has alternative blocks for THR,
Dr.
Yes, sir.
Sanika.
Dr. Sani. So just want to know, you have told about, have you heard about this pericapsular hip block?
Yes, sir. The pericapsular posterior deep gluteal block. Yes, sir.
One is deep gluteal block and one is pericapsular block.
Yes,
Although
sir.
looks
We
like
have.
same only both, but technique is both, so techniques are different.
Okay, sir. We have.
Like just for another way, they can ask pericapsular block. The technique is different. Probe position is different. In this, you are putting probe in deep gluteal. You are putting probe in the along the femoral line, right? Along the
Yes, sir.
femur.
Yes, along the axis,
In
long
that,
axis.
you are putting probe transverse between the PSIS and GT line on that line.
Okay, sir.
When you connect PSIS and GT on that line, you will put the probe and you will go towards the GT. And when the GT and the femur, neck of the femur and iliac, they will come in same line. They are under the piriformis. You will deposit that. That is pericapsular. That is just for extra. If you give good answers, then the examiner can ask last all these difference between all these alternative blocks. So just
Okay,
want
sir.
to know about the PENG. You have given the PENG. Then you can combine PENG with the LFCN. Na? Why you
Yes,
are
sir.
giving PENG plus this your block? Okay, QL block. What is the nerve which the QL is blocking?
Sir, from
Anterior
T7
QL,
to L1, sir.
L1. And what is the hip nerve supply of hip?
Sir, it is mainly from the lumbar and the sacral plexus. So majorly from the femoral nerve, which is L2, 3,
What
and
is
4,
and sciatic nerve if you cover nerve to quadriceps and all.
L5.
So
Yes,
the how the
L.
QL is working there? It is covering up to L1 only, but here nerve supply is starting from L2.
Yes, sir. Sir, if it injected in the anterior, like in the anterior thoracolumbar fascia, the drug may spread into the lumbar plexus.
May
So
spread.
yes, sir. It may
But
spread.
in literature everywhere they have mentioned it is covered up to L1 only.
Yes, sir.
So if you are giving patient analgesia, you can't depend on May, right? If it's spread, patient will get better. If it's spread to this area, patient will feel. No, you are giving analgesia, right?
Yes, sir.
Surgeon will say why you are like doubt of if it's spread. You should have concrete point to discuss with the surgeon, right? You are giving QL, why you are giving QL?
Sir, sometimes
Any
we actually, yes, sir.
yeah, tell me.
We give about 20 to 30 ml of local anesthetic in the QL block, and sometimes, so if we scan in the fascia iliaca region, sometimes this drug does spread over to the fascia iliaca, so that can be a possible mechanism of action. Also, recently we have started combining the PQLB along with the SIFI blocks, so that we can also get the dermatomal, it can block the
Yeah, but what
femoral
is the
nerve and
role of QL then? If you are giving CP and drug from QL also drug has to reach CP area. If drug from
yes, sir.
QL has to reach CP and you are giving CP plus QL.
So from the thoracolumbar fascia, the drug will go into the fascia transversalis plane, and then that communicates with the fascia iliaca. So the drug
That I
spread is
understand.
to,
That I understand. But you are giving fascia iliaca block separately and you are giving QL
yes,
block also. When drug ultimately has to reach fascia iliaca, then what's the use or role of QL block in that? If you have to block at the level of fascia iliaca only.
okay, so
No. So better I give either fascia iliaca block. If you want of more of muscle weakness, go with the PENG block with LFCL.
yes, sir.
Or QL block, if you are telling it is reaching to fascia iliaca block, then don't give CFI. Then club QL, if you're clubbing with PENG, maybe extra benefit, but you are crossing the volume also. PENG also you are giving 20 ml, there also you are giving 30 ml. So around 50, 60 ml you are giving in a 60, 70-year-old patient. Just calculate the drug and just uh, see that.
Yes,
Okay. Yeah,
yes.
thank you.
Thank you, sir.
Sir,
Thank you, Viral. Thank you.
Thank you, sir.
I
Yeah.
will close now, I think.
So we have a quiz also by Dr. Sanghamitra, the KAHOOT quiz. Thank you to all the speakers for such wonderful talk, and thank you to all the moderators for wonderful discussions. I would request Dr. Sanghamitra to take over and
I
start with the
will,
quiz.
I will try to start the quiz. Actually, the time is very short. Let's see. Let's see.
Okay.
Actually, I have kept it till 9 o'clock expecting K. Let's see.
Okay. Sure.
I have just
Thank you,
kept 10
everyone.
o'clock. I don't know it's showing or not. Yeah. Is my screen visible?
Yes, it's visible.
So I would like the fellows to join a bit faster. I have just kept 10 simple questions because we are out of time right now. I would request the mentors to continue their, if they don't want to attend the quiz, it's okay. we will continue here with the fellows.
Thank you to all the moderators, sir.
Thank you.
Thank you.
Thank you.
Thank
Good
you.
night.
Right, sir.
Thank you,
Thanks a
sir.
lot. Thank you.
Thank you, sir.
Thanks a
Thank you.
lot. Thank you. Bye-bye. Bye.
Hi,
Thank you,
sir.
sir.
Okay, only 9, so we can go ahead. I think no one else is joining. Okay, Prince is here. Shall I start the quiz, fellows? Yes, ma'am. Yeah. Today's topic was also quite big, huh? So it's okay. It
Yes,
took time,
yes,
but you people covered it mostly.
definitely.
They are still joining, Viral.
I think we can give 30 seconds more to all the fellows.
I know that this is the first time I'm getting short of time for the class,
I know.
and I really have taken the effort last minute because the person who was supposed to do the quiz has not yet sent me the questions.
Okay.
So just 10 questions.
We'll
Chalo,
finish
I'll
in
go ahead.
7 minutes. Yeah.
Yeah. Hopefully. Simple questions. It will take its own sweet time. Obturator nerve block false statement is. Okay. It's obturator neuropathy is a relative contraindication. No. Let's see. CR is, I don't know who it is, but she is leading the board. Continuous femoral nerve block. True statement is. Remember, this is fastest finger, huh? Not only correct answer, but you have to be fastest finger also. Addition of clonidine helps in prolongation of analgesia. Let's see. These are simple but tricky questions, huh? So, addition of clonidine delays motor block. Catheter should not be left for more than 72 hours, as after there is a risk of bacterial colonization. The incidence of nerve injury is around 0.25% here. Okay. Sorry, I'm putting it a bit fast. It's a multi-select. Lower limb neurological assessment. Correct statements are: plantar flexion is aided by sciatic nerve. Obturator nerve assessment is a robust indicator of sacral plexus. LFCN can be assessed by eliciting eversion of foot. Femoral branch supplies skin on medial aspect. An earliest sign of femoral block is loss of quadriceps motor power. You have multiple answers here, huh? Zero answers? Come on, fast. See, there were two correct answers. Plantar flexion is aided by sciatic, and femoral branch supplies skin on the middle aspect of the feet. I find you kids are much prepared than the earlier batch, so I have kept the questions a bit difficult. So, obturator nerve assessment is a robust indicator of lumbar plexus. LFCN is purely sensory nerve and assessed by pinch on proximal lateral thigh. Saphenous nerve is a branch of femoral nerve that supplies middle aspect of it. An earliest sign of femoral nerve block is loss on temperature on the middle side of the thigh. In adductor canal block, we avoid puncturing which of the following structure in close proximity to saphenous nerve at knee. Remember, I'm saying at knee. A tricky question. I have given a diagram also. Come on. See, I was talking about at knee, huh? Not at the ankle or at the adductor canal level, which we routinely use for giving the block. So HK is stopping. Let's see why. Because the saphenous nerve lies in close proximity to several vessels along the trajectory. Femoral artery above knee, descending genicular artery, saphenous branch at knee, and great saphenous vein in lower leg and ankle. That's why it was a simple yet tricky question. So 3 in 1 block. Thankfully not discussed today. Anterior superior iliac spine is a landmark for it. So false statement is, let's see how many of you correct this. Fast, 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 fast. Fastest fingers. The correct answer is anterior branch of optic nerve is easily visualized under ultrasound is a wrong statement. It's difficult. Okay, let's see. CR is stopping. Leg to be blocked is to be laterally rotated by 15 to 20 degree. High frequency probe is required because of superficial position of femoral nerve. Anterior branch of ON is difficult to visualize because of its location between adductor brevis and longus. So incorrect statement for femoral nerve block is fastest finger, please. Yes, larger volume does not increase the success rate, might as well lead to the complications. So HK is still topping the board. This is again a multi-select correct statement for obturator nerve R. Multiple answers, huh? Yes, divides into anterior and posterior branch in obturator foramen. Okay. Then innervates femoral artery and does not innervate knee joint. Let's see. So HK is still leading, followed by Princey and CR. Explanation. ON mostly divides after leaving foramen, but in few may divide in the canal. Subsartorial plexus is formed by ON and FN. Plexus supplies sensory branches to posterior middle aspect of inferior 1/3 of the thigh. Okay. True statement for psoas compartment block. You all know the answer. Yes, all of the above. You have to read about this a bit. So the list has changed. Princey is leading, followed by CR and HK. So adequate block can be as good as 3 in 1 block. You have to read about this, how this block is given. I will be going fast because time is less. Please read about this or we can discuss it tomorrow. A patient with preoperative popliteal nerve block given for a below knee amputation for a severely infected ischemic foot has developed foot drop in the post-op period. So the correct answer is Let's see. So CR is followed by Princey and HK. Sciatic nerve block anterior approach true statement is it suitable for hip surgery? It is also called as Beck's approach. That's the maximum hint I can give. Best suited for people who cannot be positioned in a lateral position. Catheter insertion is easy. Bone contact is required for the block. It is best suited for people who cannot be positioned in the lateral. Actually, it's a very interesting to scan this, but giving block is difficult because it is very deeply lying, but many times preferred when you cannot change the position of the patient. Suitable for operations below knee, catheter insertion is easy because of perpendicular position. Bone contact is usually the lesser trochanter. The feet should be moved laterally, which takes the trochanter out of the way of the needle. Let's see. So, congratulations, Princey. CR and third person is Dr. Razor. Okay. So, I close the Kahoot. Come back to Zoom. Yeah. So, congratulations, Princey. It was really a marathon from my side because I was worried that we might overshoot the time. But you people are prepared, and you might have realized with the quiz that it is a lot to read when you talk about hip and knee. It is almost as covering 4 master classes. So well done. Presentations were good. Only thing I will say, please restrict to time. If the first person takes 40 minutes to present, just think about the others who have prepared equally hard work with like you. Please give them time. From next time, don't force me to put a timer. Please follow the timeline. Okay?
Okay, ma'am.
Yeah, and very well presented.
Thank you,
Thank
ma'am.
you to all the
Thank you.
speakers for excellent talks. And just
Thank
Dr.
you, sir.
Sanghamitra, what she said, you just have to
Thank you,
stick to
ma'am.
the time. Okay, so I'll just stop the recording first.
Yes,
Okay.
and thank you,
Yeah.
Viral, for joining us. You're so
Most welcome.
busy and you have so many commitments, but today you were with us, so I think the kids have also enjoyed.
Thank you so much. I would definitely love to join. It was a wonderful discussion. Thank you so much. Yeah.
Thank you. Thank you and good night all.
Good night to all.
Anything you want to talk, you want to discuss, any block, any doubts you have, we can continue on